here today, and I'm going to talk about women and diabetes. There is an estimated 204 million women living with diabetes, and this number is projected to increase to 308 million by 2045. Then 50% increase in the number of women living with diabetes. 1 in 3 women with diabetes is in the reproductive age, and diabetes is the 9th cause of death in women globally, causing 2.1 million deaths yearly. And 1 in 7 births are affected by gestational diabetes. According to the International Diabetes Federation, diabetes is the 9th leading cause of death in women globally. People with diabetes, especially women, can live healthy, fulfilling lives with an interrupted supply of insulin and blood glucose test strips and equipments, combined with a healthy lifestyle. These are the important diabetes complications, and among them is the pregnant woman with diabetes or at high risk of gestational diabetes. She should manage her glycemic control throughout her pregnancy to avoid long-term consequences for herself and for the children. The transgenerational effect of diabetes with pregnancy is higher risk of obesity, higher risk of diabetes, hypertension, and kidney disease in the offspring. Then the child born to a diabetic woman is at risk for diabetes, obesity, hypertension, and kidney disease. 1 in 6 live births is affected by hyperglycemia in pregnancy. And when we talk about diabetes and pregnancy, we are talking about either preconception diabetes or gestational diabetes. And the preconceptional or the pregestational diabetes is pregnancy in a pre-existing diabetes, whether type 1 or type 2 diabetic female. And the gestational diabetes is diabetes diagnosed to the first time during pregnancy. Let me start talking about preconception diabetes. And the preconception or pre-existing diabetes, this is the natural history. 50 years ago, 2% of females with diabetes died during pregnancy, and 10% of babies were born as stillborn, and 10% of babies died during the first months of life when born to a diabetic female. Later on in 1980s, evidence of good preconception diabetes control improved the outcome. In 1990s, these data were established that if the conception hemoglobin A1C is more than 10%, there is an incidence of congenital malformation about 10% also. If the conception hemoglobin A1C is less than 7%, the congenital malformation rate is that of the general population, the same as general population. And this is the risk of fatal anomalies relative to the preconception hemoglobin A1C. When the hemoglobin A1C is high, like in this figure, 10%, 11%, or even 14 hemoglobin A1C, we're going to have higher congenital malformations in the fetus. But if the hemoglobin A1C is less than 7%, then the incidence of congenital malformation is the same like in non-diabetic females. So glycemic control preconception is essential. How to manage pregnancy in diabetics? At the preconception clinic, we should make hemoglobin A1C, serial hemoglobin A1C, and the preconception hemoglobin A1C should be less than 7%. and to stop any teratogenic medication, for example, ACE inhibitors, to stop smoking, to start folic acid 5 milligrams 3 months before pregnancy, and to check rubella status, and to switch to insulin if on oral agents. During preconception, we should do a retinal screening and to discuss potential deterioration in retinopathy and nephropathy during pregnancy, and to discuss the schedule of care in pregnancy to do albumin-creatinine ratio, and if it's increased, it's going to cause more cases of preeclampsia. The prenatal care of the mother, women should be encouraged and supported to monitor the blood glucose daily by SMBG and regularly, and to adjust their insulin dosage in order to maintain blood glucose levels within normal, non-diabetic range, and we're going to see the numbers, which is almost similar to normal blood glucose. Ladies need optimal glycemic control in pregnancy for pre-existing diabetes. We should individualize insulin therapy by bolus insulin. Bolus insulin we may use as part or Lispro instead of regular insulin. If not available, we can use the regular insulin. And for basal insulin, it's better to use DT-MER or glargine as an alternative to NPH. And to encourage patients to do SMBG pre and post-prandially. This is the Canadian Diabetes Association. And the target glucose values for fasting plasma glucose less than 95 milligram, 1 hour postprandial plasma glucose 140 milligram, 2 hours postprandial blood glucose 120 milligram. So these numbers are almost the normal figures of a non-diabetic person. So we should go to tight glycemic control for the pregnant ladies. These again are the Canadian Diabetes Association guidelines, and these are the American Association for Clinical Endocrinology and the American Diabetes Association guidelines. For patients with gestational diabetes, the pre-prandial blood glucose should be less than 95, and the post-prandial or post-meal 1 hour less than 140 and 2 hours less than 120. Again, very tight glycemic control. And for patients with pre-existing type 1 or type 2, before meals and at bedtime and overnight glucose between 60 and 99, which again are very tight numbers to reach. And for the postprandial blood glucose to be between 100 and 129 milligram per deciliter, and for hemoglobin A1C to be less than 6%. Hypoglycemia should be discussed with the pregnant female, and glucagon should be made available with clear instructions when to use and how to use. A full retinal assessment should be taken in all women with pre-existing diabetes during the first trimester. Hypoglycemia, the pathophysiology of hypoglycemia, it may be due to fetal absorption of glucose from the maternal bloodstream through the placenta during the periods of maternal fasting. And the risk factors of hypoglycemia during pregnancy is history of severe hypoglycemia before pregnancy, impaired hypoglycemic awareness, longer duration of diabetes, and hemoglobin A1C less than 6.5 at the first pregnancy visit, and high daily insulin dosage. Some causes of iatrogenic hypoglycemia: administration of too much insulin, skipping a meal, or exercising more than usual. The clinical consequences of hypoglycemia: we have signs of hypoglycemia like anxiety, confusion, dizziness, headache, hunger, pains, nausea, palpitations, sweating, tremors, warmth, and weakness. And there is a risk of hypoglycemic coma, traffic accident, or even death. Severe hypoglycemia can lead to maternal seizures or hypoxia. And the management of hypoglycemia is to inform the patient of increased risk of severe hypoglycemia and to educate the patient how to manage hypoglycemia, to do SMBG frequently, to take regular meals, and accurate medication and administration of insulin, and careful management of exercise program. This is the treatment of hypoglycemia during pregnancy. If suspected or confirmed hypoglycemia with blood glucose less than 60, then we should detect either mild to moderate hypoglycemia when the patient can swallow, or severe hypoglycemia. For mild or moderate hypoglycemia and patient can swallow, we give 15 to 20 gram glucose and maybe a fast-acting carbohydrate like non-fat milk or juice. After 15 minutes, we recheck the SMBG. If higher than 60, then to take a meal. If not resolved, we repeat the treatment with the glucose or the milk or juice. If there is severe hypoglycemia, to give 1 milligram glucagon injected subcutaneously and to request emergency assistance. Managing diabetes during pregnancy by retinal screening. If no retinopathy, then to repeat the retinal screening every trimester. If retinopathy, refer to ophthalmologist, and we should discuss that there may be deteriorating retinopathy due to vasoactive or angiogenic factors during pregnancy. Creatinine and albumin creatinine ratio to be measured in early pregnancy, and if abnormal, to repeat each trimester. And most deterioration of nephropathy is reversible, and microalbuminuria, if present, it doubles the risk of preeclampsia. During prenatal care, all women with diabetes should be referred to ultrasound. And this is the job of the obstetrician, and all should be offered detailed anomaly ultrasound between 18 and 22 weeks of pregnancy, and serial ultrasound during the third trimester to monitor the fetal growth. If delivery is indicated between or before 34 weeks, administration of corticosteroid should be considered to prevent neonatal respiratory distress syndrome. Labor or delivery care. The mode and timing of delivery should be determined by the gynecologist on individual basis, aiming to realize a spontaneous vaginal delivery if possible by no later than 40 weeks of gestation, and possibly not later than 38th week of pregnancy. Intravenous dextrose and insulin should be administered during labor and delivery. Care of the baby by the neonatologist. A baby blood glucose test every 4 to 6 hours, and hypoglycemia diagnosed with word-based glucose electrode or lab method. Hypoglycemia management by the neonatologist. And these are the problems of diabetes during pregnancy. Ladies with diabetes have difficulty conceiving with very poor control of diabetes and increased first trimester miscarriage rate, macrosomia and polyhydramnios, obstructed labor, shoulder dystocia, birth injuries, unstable lie, cord prolapse, preterm labor. placental insufficiency, preterm delivery, preeclampsia, increased risk of infections, and diabetic ketoacidosis, which may be fatal to the fetus, and neonatal hypoglycemia. Again, raised incidence of intrauterine deaths, particularly after 36 weeks of pregnancy, may be due to chronic hypoxia, hyperglycemia, and lactic acidosis. No pregnancy with pre-existing diabetes should go more than 40 weeks, and usually the aim is to deliver between 38 to 39th week. Few slides about gestational diabetes. Gestational diabetes, does it matter or not? These are the fetal complications of gestational diabetes: high birth weight or small for gestational age, macrosomia, hypoglycemia, this mature baby respiratory distress syndrome, birth defects, preeclampsia, and mothers, 50% of them are going to have type 2 diabetes later on, and babies are at risk for childhood obesity and type 2 diabetes later. When to screen for gestational diabetes? In those ladies with previous gestational diabetes, persistent glycosuria, previous large babies more than 4 kilograms, current large baby more than 95th percentile, polyhydramnios, first degree relative with diabetes, previous unexplained stillbirth, polycystic ovary syndrome, and body mass index more than 35, and certain ethnicity like Asian and African Caribbean. What to do postpartum for gestational diabetes? 6 weeks after delivery, we should repeat the 75-gram oral glucose tolerance test to exclude the ongoing diabetes or impaired glucose tolerance. There is an opportunity to reduce the risk of type 2 diabetes in the future and to screen for presence of type 2 diabetes at the moment. Angelina Jolie, famous celebrity, she had gestational diabetes and she was using insulin injection. Thank you very much.
افتحها ازاي انا دي؟ As for your very elegant talk.
We have some questions here, Professor Omar.
I see them.
What types of insulin to use during pregnancy? We said we are using short-acting or rapidly acting insulin, like insulin analog, rapidly acting, or if not, then short-acting human insulin. And we use basal insulin like insulin Clargine or Levemir. What are the predisposing factors for gestational diabetes? The predisposing factors are previous gestational diabetes, obesity, age above 35, family history of diabetes, previous delivery to a large baby 4 kilograms or more. These are the most important factors and also the presence of polycystic ovary syndrome. Is الأسئلة chat يا جماعة.
أنا كده الشاشة راحت من عندي.
Pure spot please.
أيوة كده.
Okay.
بص
Is Clargine safe in pregnancy? Yes, it's mentioned in the AGA, American Association of Clinical Endocrinology, and the Canadian guidelines. It is safe. It's class B safety, but it is recommended by the guidelines in AGA and in Canadian guidelines. What is the dose of cortisone for pregnant women? This is the job actually of the obstetrician, not ours. But using corticosteroids is going to increase the blood glucose, and you're going to increase the insulin dose to adjust the blood glucose again. Oral hypoglycemic medications during breastfeeding, should we use, or insulin is a preferred? Insulin is the preferred, and if the patient can take metformin, metformin is safe during breastfeeding, but insulin is the safest medication during breastfeeding. Numbers for diagnosing gestational diabetes. The numbers for diagnosis of gestational diabetes is too tight. It's any increase above the normal blood glucose is considered gestational diabetes. Management of diabetic women with status asthmaticus. These two conditions should be managed separately, but for status asthmaticus, you either use local corticosteroids if is effective, but if not, you're going to use injections, so the blood glucose is going to be higher and you're going to increase the insulin dose. When I stop metformin in pregnancy, if the pregnant lady got pregnant using while using metformin, then you should continue the metformin. And if you wish to start metformin during pregnancy, most gynecologists agree on this, but you should take the permission of the gynecologist. Impaired glucose tolerance for the first time in pregnancy should be treated like frank gestational diabetes, yes. When to give metformin as a prevention for diabetes? Metformin can be used for prevention of diabetes in pre-diabetic persons according to the AGA, starting from AGA guidelines 2011 until now. What types of treatment with lactation? We said we can use metformin if it's enough. If not, then we add insulin or we give shift to insulin. If there is dyslipidemia during pregnancy, we should ignore anything except for diabetes control and taking care of the pregnant lady during pregnancy. What is the pathophysiology of gestational diabetes? Yes, I don't know why this slide was kept. It is due to hormones from the placenta that increase the insulin resistance, like progesterone, lactogen, estrogen, and growth hormones and corticosteroids. They are secreted by the placenta during pregnancy. That's why gestational diabetes is diagnosed during the second and third trimester, and it's not diagnosed during the first trimester. What about mixed-stard in pregnancy if basal bolus is not available? It's not recommended. We should make tight glycemic control like we saw the figures, and this is not achieved except by basal bolus regime. Which type of insulin? We mentioned time screening 24 to 28 weeks. Type 1 diabetes, obese pregnant woman, how much carbohydrate given to lose weight during pregnancy and to control diabetes? in an obese lady with type 1 diabetes, our aim, in my opinion, would be just not to increase the weight during pregnancy, because we know that pregnancy causes about 10 kilograms increase. If we succeed not to increase these 10 kilograms, then we have lost 10 kilograms. So you try to give calories enough for the ladies, calories about 2,000 calories per day, but trying to lose weight, not to lose weight, just to prevent increased weight during pregnancy. Which type of insulin? I think we said which type of insulin is preferred for gestational diabetes. Gestational diabetes is like diabetes with pregnancy, is the same types of insulin. Insulin glargine, insulin Levemir, and short-acting insulin, whether human insulin or rapidly acting analogs. I think this is all, Professor Amr. Thank you very much.